I welcome you all to this instruction course on HSV keratitis. Even after 25 years of first results of head studies that were published, HSV keratitis remains an enigma to every ophthalmologist. The varied presentations that it comes with brings it with it a lot of challenges for clinicians, general ophthalmologists, as well as cornea specialists. And today we have structured this instruction course in a manner to simplify managing HSV keratitis for most people so that the errors that we create in terms of diagnosing and managing these patients, dealing with their recurrences and the long-term outcomes can be improved in a much simplified manner. There are many aspects of HSV even after heads which remain very blurry, and we have come together as a group to simplify those aspects for the people practicing ophthalmology where they see a lot of patients of HSV keratitis. So, without any delay, I'll introduce our first speaker, Dr. Pranita Sahai. So, first, let us go back to head study and see what we missed while learning head study. So, Dr. Pranita Sahai, she is a ex-senior resident and postgraduate from All India Institute of Medical Sciences and currently working as a consultant in Center for Sight, Delhi.
Thank you, Dr. Vikas, for the introduction, and also thank you for inviting me as a co-instructor in your instruction course. Good morning, everyone. I'm Dr. Pranita Sahai, and I'll be discussing about the head study. Sorry, I have a bad voice, so please pardon me for that. So as we all know that herpetic infections are endemic throughout the world, and the high rates of HSV infection is often an economic burden. There are a lot of questions related to oral antivirals and topical corticosteroids that are yet unanswered for viral keratitis. That is what led to the advent of HEADS trial. So the head study is divided into part 1 and part 2, each of which had 3 subparts, each dealing with a specific question that had to be answered. So in heads 1, the first one was stromal keratitis, the role of topical steroids. Second one was stromal keratitis, role of oral antivirals. And the third was herpetic iridocyclitis, the role of oral antivirals in them. So let's see each one of them individually. So the first study was herpetic stromal viral keratitis, wherein the patients were divided into 2 groups. One, all the patients at baseline were on topical antivirals, and they were classified into 2 parts. One, who were given topical steroids in addition to topical antivirals, and the other ones who were treated with placebo therapy. So now it was noted that the time to treatment failure was less in the steroid group. The failures were higher in placebo groups. However, at 16 weeks follow-up, the failure rates increased in the steroid groups. So in this study, it was seen that the topical steroids led to a faster resolution and lower percentage of treatment failures was seen with topical steroids. Looking at the treatment success, again, the median time to resolution was less with steroids, success was better with steroids. However, no difference was seen in the final visual acuity at the last follow-up. So the take point from this study was the 10-week of corticosteroid therapy was a short duration for treating stromal keratitis, because at 16 weeks, almost 50% of the patients who were on steroid therapy ended up in failure, probably because of an earlier cessation of steroid therapy. Hence, steroids may be tapered slowly in cases of herpetic stromal keratitis, and definitely steroids led to a better response compared to placebos. The second study was in patients of stromal keratitis who were already on topical steroids and topical antivirals. They were again now divided into 2 groups, one who received oral antivirals and the second who were on placebo. In this study, oral acyclovir was given as a 400 mg 5 times per day dosing for 10 weeks. It was seen that there was no statistically significant difference between the 2 groups. The failures were similar in the 2 groups, whether they received oral acyclovir or placebo. The resolution or the treatment success was also similar in the 2 groups. Hence, there was no benefit of adding oral antivirals in patients of stromal keratitis. Moving on to the third part of HEDS1, that was the herpetic stromal viral keratitis iridocyclitis subgroup. In this, the target sample size was 104. However, adequate patients could not be recruited. In this study, oral acyclovir was compared with placebos, whether it helped in an early resolution in cases of iridocyclitis. It was seen that treatment failures were less in acyclovir group compared to placebo. So there was an advantage of adding oral acyclovir. However, this cannot be definitely commented upon because an adequate sample size could not be collected in this study. Now moving on to HEDS2, in this there were again 3 subparts. The first one dealt with epithelial keratitis, role of oral antivirals. The second one was an acyclovir prophylaxis trial. And the third one assessed the risk factors for herpetic viral keratitis. So dealing it one by one, first one, that is the epithelial keratitis. These patients were already on topical antivirals, and the role of oral acyclovir was compared with placebos in cases of epithelial keratitis. So now it was observed that the risk of developing stromal keratitis or iritis following an epithelial keratitis was almost similar whether you gave acyclovir or a placebo. So there was no definite advantage of adding oral acyclovir in patients of epithelial viral keratitis. But it was also noted that those patients who had a prior history of stromal keratitis in the background of epithelial keratitis did have a higher risk of developing subsequent stromal keratitis, wherein oral acyclovir could be considered. The second part was the acyclovir prophylaxis trial, wherein oral acyclovir, the patients who had past history of viral keratitis in the last 1 year but had a recurrence-free time of at least 30 days were divided into 2 groups. One group received acyclovir 400 milligram BD dose, which is the prophylactic dose that we routinely follow nowadays, was compared with the placebo group. Now it was observed that the patient who received acyclovir did show a reduced recurrence, especially for stromal keratitis. The risk of recurrence was reduced from 13% to 8%, which is almost a 50% decline. Hence, it was concluded that acyclovir reduced the probability of a recurrence by almost 50%, especially for stromal keratitis. Now the last part, okay, also an extended observation period was given in the acyclovir prevention trial, where the benefit of acyclovir prophylaxis was assessed beyond the time that acyclovir was given. It was observed that after you stop the acyclovir prophylaxis, the risk of developing recurrences was similar in both the groups, whether you gave prophylaxis or no prophylaxis. Hence, the benefit of acyclovir prophylaxis does not extend beyond the time you're giving the prophylaxis. However, there was also no rebound increase in recurrences after stopping the prophylactic therapy. So to conclude, the oral acyclovir had a benefit effect in reducing the risk of recurrences, and the risk-benefit ratio of impact of disease and cost needs to be considered before you give this prophylactic therapy. And long-term prophylaxis for epithelial keratitis is not something that is needed. The last part is the recurrence factor study, wherein both environmental, psychological, and stress factors were evaluated in the risk of recurrences for herpetic eye disease. The outcomes of this study did not give any conclusive results, and there were no risk factors that were found. Hence, the key points to take from the HED study were that for epithelial keratitis, no prophylactic use of oral acyclovir is needed. For stromal keratitis, prophylaxis can be beneficial. To manage stromal keratitis, steroids can be helpful, and oral antivirals may not have an additional role. Thank you.
Thank you, Dr. Pranita. So we'll move to the second talk
Yes,
which
thank
is
you.
on HSV epithelial keratitis, the pearls for practical management, by Dr. Simmi Chaudhary. Dr. Simmi did her post graduation from Maulana Azad Medical College, Guru Nanak Eye Center, and then did fellowship in cornea from LV Prasad Eye Institute, Hyderabad, and is currently practicing as faculty consultant in LV Prasad Eye Institute, Hyderabad. So till the time the presentation loads, I think two important aspects from heads that people often miss is number one, uh, that the steroid therapy for 10 weeks was insufficient for stromal keratitis patients. Almost 50% patients had recurrence within 6 weeks of stopping the steroids at 10 weeks. So tapering of steroids in stromal keratitis is not the same as you do in anterior uveitis, for example. Second is that uh, even with acyclovir prophylaxis, there was significant recurrence that was noted. And third, that even if there was a delay in starting steroids, the final outcome was not affected in the patients. Over to you, Simi.
Uh, Good morning, everyone. Thank you, AIOC, for giving me the opportunity, and thank you, Dr. Vikas, for inviting me as a co-instructor. I will be presenting a few clinical pearls in the management of HSV epithelial keratitis. So, the epithelial involvement can either present in the form of infectious or neurotrophic keratopathy. Those presenting with infectious epithelial keratitis can either have symptoms, can have clinical features in the form of corneal vesicles, dendritic ulcers, geographical or marginal ulcers. So these patients present with symptoms of photophobia, pain, watering, and decreased vision. And when examined on slit lamp, the earliest finding can be a small raised vesicular epithelial lesion, which, because is raised above the surrounding epithelium, thus stains negatively, and later these vesicles coalesce to form dendritic or geographical ulcers. These dendritic ulcers are branching linear lesions with terminal bulbs and have swollen borders, which harbor live virus. And they have a classical staining pattern where the ulcer stains positive with fluorescein along the entire length of the lesion, while the epithelial margins being raised above the surrounding epithelium stain negative. And when these are when they are stained with rose bengal, they stain positive. So the epithelial borders stain positive rose bengal. A clinical tip here for all the clinicians is that whenever we aim to send the corneal scraping for viral culture, it is better to avoid prior staining with rose bengal, as it tends to inhibit HSV and thus can yield a negative report. And the clinical staining pattern helps differentiate the typical dendritic HSV lesion from various other pseudodendritic lesions, which can mimic the similar presentation. However, there is absence of terminal bulbs in other causes of pseudodendrites. In patients where these patients with dendritic ulcers, when are treated with topical corticosteroids or are long standing, then their dendrites tend to merge together to form a widened lesion, which is called as geographical ulcer, which have scalloped borders and have longer duration of symptoms. These needs to be differentiated from neurotrophic epitheliopathy, as those lesions will have smooth borders instead of scalloped borders. Coming to marginal ulcers, where the epithelial ulcer will be associated along with stromal cellularity or stromal infiltration because of intense limbal injection adjacent. There is absence of lucid interval, and these, when progress, tends to progress centrally towards the visual axis, which is as opposite or as opposed to any other cause of bacterial uh, blepharitis, where the progression happens centripetally along the circumferentially along the limbus. Uh, another another entity is neurotrophic keratopathy, where it is neither infectious nor immune, but instead is because of the impaired corneal innervations and decreased tear secretion. And these present in the form of irregular epithelium and lustreless cornea, and eventually will develop an epithelial defect which have oval and smooth thickened borders. Uh, Talking about some treatment pearls is that the dendritic or geographical ulcers The main aim of treatment here is to get rid of the live virus. And the mainstay of treatment is topical antiviral agents, where we can either use acyclovir 3% or ganciclovir 0.15%, and they bind to DNA polymerase and acts like a chain terminator. The eye ointment Acivir is to be given 5 times a day for 21 days. And if the patient is severely symptomatic because of the epithelial defect, then topical cycloplegics can be used to relieve ciliary spasm. Also, prophylactic antibiotics can be given 3 to 4 times a day for large geographical ulcers, just to reduce the risk of secondary infection. And lubricating eye drops can be given for large ulcers. There is a study by Kolam et al. Where they published that oral acyclovir is as effective as topical acyclovir. The indications here are that they can be supplemented in cases with precious grafts. However, they can also be considered, oral acyclovir can also be considered for compromised ocular surface, as well as those patients who are intolerant to topical acyclovir. Having said that, in the clinical experience, these are very well tolerated and are not so toxic to the ocular surface. The duration of treatment is to be 5 times daily for 21 days, even when you have seen that over 4 or 5 days or maybe a week, the dendritic lesion or the epithelial lesion has healed. And longer periods may be needed for geographical ulcers. The role of topical steroids is strictly contraindicated when you are dealing with active dendritic lesions. However, it can be supplemented when there are anterior stromal cellularity along with the dendritic lesion. However, when the dendrites are in the resolving stage. Talking about the management of the neurotrophic keratopathy, here it's better to stop the antivirals and give the patient with intensive lubricants 1 to 2 hourly. Also, along with that, a prophylactic antibiotic to reduce the risk of secondary infection. And the mainstay here is to do a tarsorrhaphy for the persistent epithelial defects or ulcers. In case it doesn't heal, then it can be supplemented with amniotic membrane grafting. This is a patient who had come with a persistent epithelial defect post HSV keratitis, where we did a tarsorrhaphy, and 2 weeks post tarsorrhaphy, the epithelial defect has healed completely. This is another patient with neurotrophic ulcer, which started showing the signs of healing 5 days post tarsorrhaphy and eventually healed 3 weeks post tarsorrhaphy. So again, in conclusion, in patients with neurotrophic keratopathy, tarsorrhaphy along with intensive lubricants play a very important role. Thank you.
Epithelial keratitis, if any queries anyone has, they can frankly ask. So I'll be speaking on HSV stromal keratitis and how to minimize the complications and recurrences in cases of HSV stromal keratitis. What makes HSV stromal keratitis such a challenging disease? So the multifaceted aspects of this disease, the diagnosis is very challenging in many of the cases. It is a great mimicker of different infections, and therefore the diagnosis always you're in doubt whether you are dealing with HSV or you're dealing with some other infection. You're often confused whether to give oral Acivir or topical Acivir in these cases, especially in the beginning, whether you should start on topical and then shift to oral, start on oral itself, or give both the therapies together. You are unsure how to taper the steroids. Most physicians, clinicians taper it in a regular manner from 10, 6, 8, 6, 5, 4, 3, 2, 1, like how you do weekly taper for anterior uveitis cases. And you're not sure how long to treat these patients, how long to keep them on Acivir, how long to keep the prophylaxis on, how long to keep the steroids on. And you're often dealt with blows of recurrences, that the patient is doing well and suddenly comes with a significant recurrence of stromal keratitis or has an epithelial lesion or has a necrotizing stromal keratitis. And the whole cycle keeps repeating and repeating, and you're in a rut in terms of having unhappy patients because they are coming up with recurrences repeatedly to you. So immune stromal keratitis very basically typically presents with recent onset decrease of vision for the patient with mild pain and mild congestion. Usually the pain is not very significant in these patients because the epithelial defect is not there. there is stromal inflammation and infiltration that you can see. There will be cellularity that you will see. There will be mild edema, much lesser than what you see in endothelitis patients. So the edema will be there, but it's much lesser as compared to endothelitis patient. These patients also may have keratic precipitates, but usually they are not very large keratic precipitates in these patients. So to make diagnosis easier, one thing that you should do in stromal keratitis patients, because often these patients have had recurrences. So look for the clues that support your diagnosis. Ask for proper history of whether they have had recurrent episodes. Ask them whether they have had any redness, whether they have visited any doctor previously, whether they have had any treatment previously. Look for footprint scars. Footprint scars will tell you, they sometimes may be very faint scars. They'll tell you that this patient has had some episode of any form of keratitis previously, probably HSV. And look for any ghost vessels or vascularization that you can see within the stroma. The best way to look for vascularization in ghost vessels is in retroillumination on the slit lamp with a dilated pupil completely. That way you will not miss the ghost vessels. So let's look at a case, very typical case, 35-year-old female on with a BCV of 20-50, patient already on tablet Acevir prophylaxis BD and has presented with a recurrent episode where you see there is significant stromal infiltration. The patient has presented with decrease of vision at this point. So the question arises, for this patient, do I add topical Acevir or just step up the oral Acevir that the patient is already on? Second, what steroid frequency should I start on and how do I taper the steroids in this particular patient? And third, this recurrence has happened in the patient when the patient was already on Acevir prophylaxis. So what needs to be done about that? So let's look at each aspect one by one. So let's look at oral antivirals versus topical therapy. As Dr. Simi already said that oral versus topical therapy has equal results in terms of epithelial keratitis. But here in immune stromal keratitis, you have to understand you are giving topical or oral therapy at the time of acute disease only for prophylactic role to prevent epithelial lesion from happening. So it is not an active infection that you are dealing with. So the role here of topical versus oral is only as a prophylaxis to prevent epithelial lesion happening. And oral Acevir is equally efficacious as topical for epithelial keratitis. So here also you can either step up the oral Acevir or you can keep the oral Acevir BD and add topical Acevir over it. This has to be continued at 5 times per day dose, whether oral or topical, till the steroids use is more than 4 times per day. So this has to be understood that the dose has to be 5 times per day till the steroids are more than 4 times per day. Now, you prefer oral Acevir where there is associated ocular surface issue in the patient, where you expect that there is some neurotrophic component. If it's a graft, then definitely oral Acevir would be preferable. So in wherever you feel there is a dry eye component, patient has severe MGD associated, so you prefer oral Acevir. Also in many of my patients, I prefer stepping up the oral Acevir from BD to 5 times dosage rather than adding a gel or an ointment. The reason being that the patient is already on that treatment, it's easy to explain to the patient to just step it up for some time. Acevir is a very safe drug overall, long-term studies have shown that. Second, the ointment causes some blurring, additional blurring to the patient, and they are not very comfortable putting the ointment in some patients. Those patients, the gel formulation of ganciclovir has better tolerance. So when you look at the HEADS trial, two things are important. The faster resolution was noted with topical steroids, but the time of initiation of therapy did not affect the final outcome. So even if you started the topical steroids later on, then also the final outcome was similar. And there was recurrence of disease in 50% of the patients within 6 weeks of stopping the steroids. So that what it means is that the steroid therapy for 10 weeks is insufficient for stromal keratitis patients. And it needs to be tapered more slowly, and the lower the dosing becomes, the longer can be the tapering period. So you can't keep it on 10 times per day for 5 weeks. So you have to reduce initially and then make the tapering period longer when the dosage becomes lower. So what regimen usually we follow or I follow is that I start with prednisolone acetate 8 to 10 times per day and taper weekly till the dosing reaches 4 times per day. At this point, I'm either using oral or topical Acivir 5 times per day till the patient has reached 4 times per day dosing. And then slow down the tapering further. What do I mean by that? That when I make it 3 times per day, the dosage period will become 2 weeks. When I make it 2 times per day, the dosage period will become 3 weeks. When I make it 1 time per day, the dosage period will become 4 weeks. And even after that, if this patient has had previous recurrences, I would shift to alternate day or twice or once a week dose for a much longer period, maybe another 1 month or 2 months, till I know that entire inflammation period has gone down. And during this period, I will keep the patient on oral Acivir 400 mg BD. So how to deal with recurrences now? How long to continue on maintenance for these patients, and the disease is still recurring with Acivir, so what to do in those cases? So you have to understand the efficacy of antivirals in preventing recurrent episodes is only 41% reduction in recurrences and 50% reduction in stromal keratitis cases. The more the number of previous episodes that the patient has had, the more the risk of recurrences, and shorter is the period between the different episodes. So if the patient has already had multiple episodes, this patient is likely to recur more and more. So the benefit of using oral antivirals also prophylaxis also lasts only till the patient is on the prophylaxis. So you can't expect that you give for 6 months and hope that the effect will last another 6 months. That will not happen. And also, well, acyclovir and famciclovir are equally efficacious. So if you want to keep a lesser frequency dosing, you can shift to valacyclovir OD dosage. So repeated recurrences on prophylaxis you are having, what you might be doing wrong in that patient. First thing to look at is, are you tapering the steroids too fast? That means you have to maintain this patient on lower dosage of steroids for a longer period to keep the inflammation in check. This is the most common cause of the patient having recurrences, that you're tapering the steroids too fast. Second, if the patient is having recurrences repeatedly with this dosage of Acivir, do you need to increase the dosage? So there are studies which have shown that at least 800 mg is needed per day for reducing the recurrences, and recurrence rates are higher at lower dosage than that. And there are also studies which have shown that slightly higher than 800 mg does reduce the recurrence rates, but they are not randomized trials, so we don't know the complete efficacy of that. But yes, you can shift the patient to higher dosage 400 mg 3 times per day, or you can increase the dosage to 800 mg BD also. Again, you have to keep the renal function test in check, but overall very safe. And if the patient is having repeated recurrences, there's no harm in increasing the dosage. Or are you dealing with a resistant strain? Now this is a tricky one, and usually we don't, most people will not have the facility to know whether you are dealing with a resistant strain. You can consider alternatives, but I will say that this is a very rare scenario in our clinical setup. So 3 mistakes to avoid while dealing with stromal keratitis. Do not rush to start topical steroids. If you are doubtful about your diagnosis, there's no harm in delaying for a few days and then starting the steroids. Just see the response on your antibiotics. If you're unsure about whether it's infective, send a corneal scraping if you feel there is an infiltration capable of giving you some material. Do not taper the steroids too fast. This is the biggest mistake that most ophthalmologists make while treating HSV. And do not stop oral Acivir prophylaxis too soon. To conclude, knowing the interplay of steroids and antivirals is the key in treating stromal keratitis. Slow tapering of steroids and higher maintenance dose of Acivir if the patient is having repeated recurrences. And most importantly, explain to the patient what this disease is, and they have to live with it. It is not going to get completely cured. They will only stick with you as a practitioner, as an ophthalmologist, as a cornea person, if they understand that what they are dealing with is going to keep recurring, even if you are doing your best. But you are going to take them through this journey, holding their hands and taking care of every recurrence and preventing those recurrences. And you understand every time that the recurrence happens, what you are doing wrong, you have to tackle it. Okay, so talking to the patient is very, very important in Acivir. I talk to HSV patients maximally after refractive patients. So it takes almost 20-25 minutes to every fresh HSV patient to explain to them in detail that what we are dealing with, what they can expect. Because often they will come to you that I am taking Acivir, why am I coming up with recurrence again? So you have to initially itself tell them that it will only reduce your recurrences. It cannot completely stop those recurrences. So you cannot expect the patient to not have any recurrence even if they are using a severe prophylaxis. Thank you. So next we have Dr. Niket Gandhi. He will be presenting on endothelitis aspects of HSV. Dr. Niket Gandhi did his cornea fellowship from LV Prasad Eye Institute, Hyderabad, and is currently practicing in Navi Mumbai Lakshmi Eye Institute. Over to you, Niket.
So very good morning to all of you, and I would like to thank AIOC at the outset for this opportunity. So just taking you through the third aspect of HSV, that is HSV endothelitis in this IC. So it is an inflammation of the corneal endothelium which may disrupt the endothelial function and cause subsequent visual changes. And primarily, we see corneal stromal edema without any dense stromal infiltrations. So the three most important aspects of this particular entity are the stromal edema, the corneal edema, the KPs which we see behind the corneal edema, and the subsequent iritis, the simultaneous iritis which happens in these cases. So the etiology can be, if you just see this particular clinical picture, can be multifactorial. The other common viral infections are the VZV and CMV. It can be related to other medications. It can be fungal masquerading this particular entity, other zoological and environmental causes, and it may occur simultaneously with interstitial keratitis, iritis, and trabeculitis. So when we say that endothelitis is immune inflammation or an immune endothelitis, it is when the cellular immune attacks on the endothelial cells are happening, and there is a marked with HSV antigens. There are primed immune cells come in contact with the target receptors and endothelial cell membrane, and there is no direct vascular contribution as such for immune endothelitis. So, as compared to stromal keratitis, the target of inflammation is just the endothelium, and the KPs are under the areas of edema only in most of these cases. There is an absence of stromal infiltration as well as neovascularization in HSV endothelitis, and there is a chronic course may lead to intractable corneal edema or a very faint scarring which results in loss of visual acuity. Now, the confocal microscopic studies have shown that viral endothelitis may have these few features like pseudoguttate, enlarged intercellular gaps, infiltration of the inflammatory cells, and loss of defined cell boundaries of the endothelium and endothelial denudation as well. So, as you can see, the endothelium is the target of this particular entity, and it does have significant effect on the overall endothelial function. Now, the three different aspects are the disciform type, which is the most common one, the diffuse endothelitis, and a linear endothelitis as well. So, in disciform endothelitis, we see photophobia, limbal injection, iritis, and reduced visual acuity because of its location. And there is also central paracentral corneal edema, ground glass appearance, and KPs, and elevated IOP due to iritis and trabeculitis. So the treatment is quite straightforward, where it is quite sensitive to topical steroids. There is complete resolution of edemas and KPs without stromal scarring or loss of vision. In a few cases, it may be self-limiting, but in severe cases where the treatment has been delayed for quite some time, may lead to a persistent edema, scarring, and neovascularization. Now, linear endothelitis is a very rare entity. Again, it presents with pain, photophobia, and injection. Clinically, it is seen as a line of keratic precipitates on the corneal endothelium that progress centrally from the limbus, and peripheral stromal edema and epithelial edema between the KPs and the limbus. So, in a paper described case of HSV endothelitis in a post PKP patients, and as you can see, it clearly describes the area of involvement versus in the graft versus a normal cornea. Now, an entity which is known as diffuse endothelial keratitis presents with retrocorneal plaques, scattered KPs, and a diffuse stromal edema and severe iritis. It is a great masquerading and a differential diagnosis in this case is always fungal keratitis. A paper by Todokar et al. Showed how entity which mimics fungal keratitis was treated for fungal keratitis and was not responding for the same, and subsequently when they tested it in real-time PCR for HSV, they found HSV and were subsequently treated on those lines, and they found that the results were quite good. So, as far as the three forms are concerned, the disciform endothelitis can be treated with corticosteroids, topical corticosteroids alone. The diffuse will require oral acyclovir along with the topical steroids. However, the linear endothelitis, most commonly seen in post keratoplasty patients, will require oral and acyclovir and oral corticosteroids along with topical corticosteroids. Take home message is that early diagnosed endothelial keratitis can be treated with topical steroids with excellent outcomes. Differential diagnosis for endothelitis needs to be considered in cases of retrocorneal plaques, and the role of RT-PCR of aqueous humor for suspicious cases can also be considered. Thank you.
Thank you, Niket. So the difference between endothelitis and stromal keratitis, one big difference is that immune stromal keratitis is an immune entity. There's no active infection that is happening, whereas in endothelitis, there's an active infection happening. Second thing, because there's an active infection happening at the endothelial level, at a deeper level, topical acyclovir does not work for endothelitis. So any patient in which you have disproportionate edema with KPs and there's no stromal infiltration that you are seeing, or there's only mild stromal infiltration that you are seeing, then you are dealing with endothelitis. So in that, you have to remember that don't start on steroids plus topical acyclovir. In these patients, oral acyclovir is a must as compared to topical acyclovir. So oral acyclovir give a better outcome to these patients, preserving the endothelium as well, will have a better penetration as well, and better, faster resolution as well. So no topical acyclovir for endothelitis patients as compared to where we discussed about immune stromal keratitis, where topical was a choice in the initial 2-3 weeks to prevent epithelial keratitis. So in endothelitis, as an active infection, go for oral acyclovir only along with your steroids. Right? So next speaker we have Dr. Nahita Kate. She'll be speaking on HSV necrotizing keratitis. Now this entity is something which is very, very difficult to diagnose as well as treat. Dr. Nahita is faculty at LV Prasad Eye Institute, Vijayawada Center, and she did her fellowship from LV Prasad Eye Institute, Hyderabad, and previously she did her post-graduation from Jipmer, Pondicherry. Over to you, Nahita.
Thank you, Vikas. So, good morning, everyone. Today I will be discussing HSV necrotizing keratitis. When do we suspect this entity? How do we establish the diagnosis? And what are the principles of its management? So, this is perhaps the one entity in HSV keratitis which very closely mimics routine microbial keratitis. So, unless we have the clinical suspicion that this patient might have an underlying HSV infection, and because HSV diagnostics is not a part of our routine microbiological workup, we will miss out on these cases because routinely we do not ask for HSV diagnostic tests. So, how do we suspect that this patient may have an HSV infection? The first is if the patient presents with a chronic history of recurrent episodes, that they've had on and off episodes of redness, pain, and watering in their eye. The other is the presence of footprint scars, vascularization, and here specifically the presence of deep vascularization and atrophic iris patches, as can be seen in this picture here. So it is important to understand in isolation, none of these signs are specific for HSV, but when all of them are present together, this constellation suggests that the patient may have an underlying HSV infection. Another point that can indicate that this patient has an HSV infection is the color of the infiltrate. It tends to be more on the white side of the spectrum, grayish white in color, when compared to other bacterial or fungal keratitis. Now, both the images are taken from the same patient The one on the left, the patient has an isolated HSV infection, whereas the one on the right, the patient has an HSV infection with a superadded bacterial infection. So we can see the difference in the color of the infiltrate. Again, this is not a diagnostic feature, it just suggests the presence of an HSV infection. So, how do we diagnose? Now, when it comes to diagnostic tests, there are some limitations that it is very important for us to understand. The first and the most important thing is these tests are not routinely available everywhere. The second one is that it takes time for the test results to come back, and we cannot wait for these results to come to start or initiate the treatment for these cases. And the third and the most important thing is that it does not detract from the diagnosis. So if the test comes positive, it does not mean that we need to stop our antivirals, especially if the patient is responding to it. So, in the context of these facts, these are the tests that are available. And within these tests, the combination of PCR and IFA has the highest sensitivity and specificity for the diagnosis of HSV. IFA indicates the presence of the antigen and therefore it is diagnostic for an HSV infection, but this is not true for PCR. So even if you have an isolated PCR positivity, it does not indicate that the patient has an active infection, and this is because the HSV virus can be present in the tears of normal individuals. It can also be present in the corneal epithelial cells in around 15% of the population. And so to circumvent these limitations, we have tests such as RT-PCR, which quantifies how much viral load is there in the sample that we have taken, and therefore we can differentiate from a carrier status and an active infection. Now, let us look at how do we treat these cases. So we start with a therapeutic dose of oral acyclovir, which is 400 milligrams 5 times per day, and here we are talking about the oral form of acyclovir. Additionally, we start these patients on antibiotics because, like I said, we may not be entirely sure that the patient is in fact a case of HSV keratitis, necrotizing keratitis, because in these patients they will have an epithelial defect and infiltrate very similar to that of a routine microbial keratitis. Subsequently, we monitor the healing of the epithelial defect, the healing of the infiltrate, and when the culture comes back negative, and in the combination of these two factors, it is only then that we start the patients on topical steroids. Now here, the starting of the topical steroids is different from that of immune stromal keratitis, because in immune stromal keratitis, we start them at a higher dose, but here we start them at a low dose, 4 or 5 times per day. Again, slowly assess the response to therapy and then subsequently increase the dose. Once the dose has been increased, the tapering is very similar to that of immune stromal keratitis. So let us see these principles in the context of some cases. So this was a 53-year-old female who presented with this inferior paracentral infiltrate. You can see the color of the infiltrate is grayish white. There is a front of vascularization inferiorly, and there's an overlying epithelial defect. So the patient was subjected to a scraping, which was negative. And so the patient was started, because the clinical picture was suggestive of HSV necrotizing keratitis, the patient was directly started on oral acyclovir along with prophylactic antibiotics and cycloplegics. Subsequently, this was the response to therapy on oral acyclovir. We can see there is a decrease in the infiltrate. There's also a near resolution of the epithelial defect. Subsequently, the cultures were negative. The IFA PCR was also negative, and so the patient was started on topical corticosteroids 4 times a day. And this was the response to the topical corticosteroids. Slowly, the dose was hiked up and then tapered. There was complete resolution with scar formation. This is another patient who had a long-standing history, and this is what a chronic case of HSV keratitis often looks like. The patient will have footprint scars, significant vascularization. The surface may be unhealthy because of associated neurotrophic keratopathy. Here, there is an epithelial defect with significant infiltration and hypopion. There was thinning, so the patient underwent a TA-BCL and was started on prophylactic antibiotics and oral acyclovir, the therapeutic dose. And with this itself, there was a significant response. And again, the culture was negative, and so the patient was started on topical corticosteroids, and the patient had a very good response with the same. Now, this case I wanted to show because there can be this type of a picture, and it really helps us identify that this patient has an HSV infiltrate. So here, if we see, there is an inferior infiltrate, and on staining, the margins of the infiltrate have the typical scalloped appearance of a geographic ulcer. So this is also an indicator that the patient has an HSV infection. And if we go back to the first picture, we can see here the lesion that is extending from it also has a dendritic pattern of infiltration. So a very careful clinical examination can help us differentiate the microbial keratitis patients from the HSV keratitis patients. So this patient also again responded very well to oral acyclovir, and then subsequently we started on topical steroids, and there was a good response. This is another case where we can see that the epithelial defect has a very classical picture. The margins are tapered and there's a dendritic pattern over here. So staining, and here we can see also the margins are taking, there is a little bit of rose bengal staining. So staining in a patient with necrotizing keratitis can give important clues as to what the underlying diagnosis is. Again, this patient had a good response, was started on topical steroids and had complete resolution. This is the last case. When you cursorily see this patient, you may again treat it in the line of bacterial or fungal keratitis. This patient has predominantly a posterior stromal and an endothelial involvement with a large overlying defect. So this patient was not very compliant to therapy and came with this kind of picture. Here, this looks has a more classical appearance of HSV because of the vascularization. And this patient on investigations was positive for both IFA and PCR. The patient, because of the thinning, underwent a TABCL and again responded very well with scarring to oral acyclovir and steroids. So to conclude, a high degree of clinical suspicion is very important to identify if the patient has an NSK infection. For this, careful clinical examination looking for the presence of vascularization, footprint scars will tell you that the patient probably has an underlying infection. Although diagnosis supplements in NSK, it is not necessary for it to be positive to start the patient on antivirals or even to continue the patient on antivirals. And for the management, oral acyclovir is what we give initially. Only after you see a response, you must start the patient on topical steroids. Thank you.
Thank you, Dr. Anahita, for a comprehensive presentation on necrotizing stromal keratitis. It really is a challenging entity, and every patient of NSK presents a different challenge to the clinician. So coming to our last talk, where I'll be talking about some of the top pearls for management. Here I will be summarizing some of the aspects which we have discussed already in our IC, and just summarizing what you should take away to your clinics from this instruction course. So the biggest aspect of HSV is that it's difficult to diagnose because it is a great mimicker. It mimics so many different types of infections, and it can present in any way. It can affect any layer of the cornea, and it can present in very, very different ways. Second is that it's very challenging to treat because it requires long-term therapy, recurrences, steroids, no steroids, oral, topical, etc. There are so many arms of its treatment that it becomes challenging to treat, and every patient might have to follow a different path of treatment. So to make the diagnosis easier, when you differentiate for a epithelial keratitis, differentiate a true dendrite from a pseudodendrite, the pseudodendrite will not represent usually a true ulcer, and there will be an absence of dual staining in these patients of pseudodendrites, and there will be no terminal knobs which are seen in patients of HSV epithelial keratitis. So as you can see in the pseudodendritic picture, that there are no terminal knobs noted here. Second, as I discussed before, look for the clues that support your diagnosis, especially the history. History is very important in HSV patients. Look for footprint scars and the vascularization and ghost vessels. So let's look at this case, who was a 48-year-old female who presented to us with on treatment for 9 months with recurrent episodes of redness and pain. You can see a lot of infiltration here and a lot of vascularization. So patient was being treated with antivirals and steroids with waxing and waning course. And we did a corneal scraping for the patient, and it came out to be microsporidia. So a PK was done for the patient. The patient had a good outcome with an eccentric graft. The important lesson from this is that very often these patients of HSV or non-HSV mimicking HSV actually have visited many consultants and many clinicians, and they have diagnosed as HSV. And they also write previously known case of HSV. And the patient comes to you, you also write previously known case of HSV. So don't fall for the trap of diagnostic momentum. Look at every patient from the beginning as a new patient, as a new aspect, and then retrospectively you can go back that yes, this might be HSV. But if we think that this has been diagnosed case of HSV, then we also treat in the same lines. Second, as I discussed before, that steroids need not be started early in even patients of immune stromal keratitis. So you don't need to rush to add steroids because the final outcome remains same. So whenever you are in doubt, do a corneal scraping. If you are suspecting any other infection, there's no harm in doing a corneal scraping, and even a basic smear will tell you about many of the organisms. And as HSV is a great mimicker of other infections, the other infections can also mimic HSV. So keep in mind these three important points. To make the treatment simplified, in patients of epithelial keratitis, topical ganciclovir is preferable because it has better tolerability or acceptability. It does not cause blurring, but it is costlier. So you have to see in terms of what the patient can afford. There's no difference in efficacy between these two agents. Second, oral versus topical therapy in patients of epithelial keratitis. As I said, prefer oral Acivir when there is an associated ocular surface issue, dry eyes or neurotrophic component, or it's a graft case. Then you prefer oral antivirals over topical for epithelial keratitis. This thing which we have often seen in our clinics is that a lot of clinicians give dual therapy. They'll start on oral as well as topical, even for epithelial keratitis. So there's no evidence that simultaneous use of two antiviral agents will accelerate healing of the HSV epithelial keratitis. So keep only on one agent, whether oral or topical. Patients with a longer healing time in epithelial HSV keratitis, these are the patients who have a large geographic ulcer or who have a limbal lesion, because there is more inflammation in limbal lesions. Patients who have associated stromal inflammations. There are many patients of HSV epithelial which will present with stromal infiltration as well. So a patient of geographical ulcer is likely to develop a geographical ulcer more in cases of delayed treatment, if the patient has been given topical steroids and or if the patient is immunocompromised. In these cases, there can be sequelae of having infiltration and residual scars in epithelial keratitis also. But in these patients, you can give soft steroids because these are superficial lesions, but antivirals need to be continued as long as the patient is on steroids. So let's look at another case. This patient had presented with a good visual acuity and was on steroids along with antivirals. But you can see there's a lot of cellularity here. You don't appreciate any epithelial defect. But when you stain the patient, you actually find an epithelial defect. And when we did a scraping for this patient, it turned out to be pythium keratitis. The patient, after stopping the steroids, has significant flare up. So from 2040, the patient went to finger counting close to face vision because of stopping of the steroids. So again, no, you should not rush to add topical steroids. So in cases of immune stromal keratitis, make sure that there is no other infection before you consider adding steroids. And again, as we discussed, immune stromal keratitis, do not rush to stop steroids as well. So these two things you should never do in immune stromal. And as we have discussed the regimen previously, a very slow tapering of the steroids in patients of immune stromal keratitis is needed to prevent recurrences. That's the most important thing, that you reduce the inflammation completely before you stop the steroids. And that completely means even at microscopic level. So what is the duration of prophylactic therapy that is needed? So how long should you continue the patient on Acivir prophylaxis? So there are many factors that you consider before you consider stopping Acivir prophylaxis. When did the patient have last recurrence? How many recurrence patient has had on prophylaxis itself? Is the patient one-eyed or has a precious corneal graft? Is there a bilateral disease in the patient? And is there any evidence of renal toxicity on renal function tests? So also you have to understand that patient will have benefit of oral Acivir only till the time the patient is on oral Acivir. So no clear guideline is there for how long you should continue it, but you can continue it as long as possible, especially if the patient is having immune stromal keratitis and having recurrences. Consider stopping when there has been no recurrence for at least last 6 months, and that is off any form of steroids. Okay, so in these patients who have not had any recurrent episodes, after stopping steroids for at least 6 months, you can consider stopping the prophylaxis. How frequently renal function tests should be done? Ideally 3 months is what is dictated, but even 4 or 5 months is sufficient enough to get the renal function test. Most important aspect of treating HSV is the counseling. You have to tell the patient this is not an local infection in itself, it's a local and systemic infection. Treatment will not cure this disease, but only reduce the recurrent episodes. You have to make them understand the prophylactic therapy has to continue for much longer if the eye needs to be saved. The recurrences may still occur on prophylaxis. The patient should know this, because then only the patient will stick to you as a clinician. Otherwise, they will keep searching for another clinician who can stop the recurrences. And explain to the patient what are the warning symptoms of recurrence, so that they seek early care and you can initiate treatment early, so that the scarring post immune stromal keratitis is much lesser. Vision will get affected with repeated episodes for the patients, so they should know the consequence of stopping oral prophylaxis on their own, which patients often do. And you can explain to them the need for repeat testing of renal function tests when the patient is on oral prophylaxis. So thank you everyone for being a patient audience. Hopefully this instruction course was useful to manage your HSV keratitis patients.